Every time we step in here to save a life, we are exposing ourselves to potential harmful effects of ionizing radiation.
We are the occupation that is exposed to the highest amount of radiation. The only other occupation that even comes close is people who work in nuclear power plants.
Radiation was not a priority. I know myself didn't wear a badge for more time than I probably should admit.
The history of radiology begins with Conrad Rankin.
As soon as he developed that film, it became an international phenomenon.
Because you couldn't see it, feel it, or really be aware of it, didn't fully understand its potentially damaging effects.
Any radiation is bad, and you don't know how your body's going to respond to it, and the effects of that radiation could come out later in life.
I think I felt this radiation cannot hurt me.
I was diagnosed with breast cancer in 2021.
The most at-risk person when it comes to radiation are young females.
I am concerned that they're putting their unborn child at risk.
It is a controversial subject and not totally proven that people that have been exposed to X-rays had developed cancer.
It's just not known yet. We're doing the experiment right now. I want you to think about why the left side of the body is so important.
When you look at interventional cardiologists with brain cancer, that over 8 out of 10 of those brain cancers are going to be on the left side.
90 to 92% of all my skin cancers were on the left side of my body.
We're really limited in the data that we're relying on.
There's another type of exposure. It's wearing these lead aprons.
Ruptured disc, completely paralyzed right leg.
Muscle wasting, foot drop.
My right leg was paralyzed. I couldn't walk for over a month. Yesterday was my last day in the OBL, so no more outpatient procedures. That passion has damaged my body to the point that now I can't even enjoy the fruits of the labor.
We as the physician community really have to speak up and have to say that you guys have to protect us.
There are other technologies right now that are available.
The newer technologies are really barrier protection. It's taking off the personal protection and giving you a community protection. So if you think of radiation as basically a source of light, then you want to stay in the shadow of that light.
Some of these new systems are very slick. You could perform 1,000 procedures a year and still only be at 2% of the maximum allowable threshold for radiation exposure.
Some of the new imaging modalities, these are important tools. It's early on in their evolution, but this idea of doing fluoroless navigation is certainly here.
Without radiation, without fluoroscopy, we can navigate this catheter inside the patient.
In a lot of these procedures, there's almost always a high-quality scan, like a CAT scan that's done beforehand. You can use that to make a really high-quality 3D map to navigate through.
Essentially, we can see wires, we can see catheters inside the patient anatomy without having to step on the radiation paddle.
We feel that low-field MR scanning will change the field because we can use conventional equipment because the magnet isn't as strong.
So this allows us to see all of the soft tissue, the vessels, the heart, whereas when we're using the X-ray, we just sort of see this gray blob in the middle of the chest and we can't actually see where we're going.
I think it's the responsibility of the health systems that we work in to put you in the safest environment, and currently we're not, and there's better options out there.
Your most important resources are your human resources. It takes people, and these people have lives, and these people have families, and these people have a future. And I can tell you, most of our staff, they leave.
What'll happen eventually will be the same thing that happened in the NFL. You'll have a group of people that have had orthopedic issues, or you'll have a group of people that have had cancers from the radiation. You'll have a class action lawsuit.
I think the good hospitals, the hospitals that really are known for being able to take care of their doctors, will generate a lot of loyalty, and that will be good for business.
I want to welcome everybody. My name is Bob Foster. I'm an interventional cardiologist, And I want to welcome you here for this webinar. It'll take about an hour, maybe a little bit over. And it's sponsored by ORSIF, which is the Organization for Occupational Radiation Safety and Health in Interventional Fluoroscopy. To my left is Dr. David Rizik, and I really appreciate him being here with me as the co-host and from Honor Health here in Arizona. And really looking forward to this opportunity. ORSIF is supported, and I want to shed light on the sponsors. These are those in the space of radiation protection, and I think they will help us join together to allow us to spread the message. We have quite a few special guests that we're going to bring in. This is going to be a very interactive type of webinar. We've got Dr. Tom Eagan from Birmingham, Alabama, J Kereiakes from Ohio State, and Dr. Rhian E Davies from York, Pennsylvania, and really looking forward to their discussions. They have a very unique version of their experiences with radiation and being in the cath lab. We're going to show clips from the film Scattered Denial, and Dr. Rizik is a big part of that, as you'll see throughout this webinar. And why make this video? Why make Scattered Denial now?
Well, I really think the simple answer is we were following the foundations that you and other pioneers set in terms of it being a call to arms, a call to action. For so long, we have worked in the cardiac catheterization laboratory. For so long, we've had radiation exposure that we really haven't considered the consequences of. We've had orthopedic burdensome lead aprons. We really didn't think of the downstream consequences of that. There was so much to this, Bob, that we felt it was time to tell this story and to tell it in the strongest terms possible. And I think as our viewers and our participants watch the clips of Scattered Denial, I think they'll agree that this is a call to action.
Great. These clips are going to be kind of a teaser. You're going to see a little bit of them during this, but it's actually going to be a 1-hour version that's going to be on PBS in July. We're premiering it online on April 28th, and that is in conjunction with the National Occupational Health and Safety Day through the World Health Organization. So we'll be able to celebrate that and hopefully create a safer environment for all of us to live in. As I said, this is interactive. If you ask some questions, please ask the questions, and hopefully we'll have a chance to answer those. But we're also going to take some polling. And so throughout this, we're going to take polling, give you the answers to those polls, just to see where everyone is in this field. So the first question that we're going to ask is, when did we first realize radiation was dangerous? When Wilhelm Röntgen first discovered it, when Thomas Edison's assistant, Clarence Dally, died from radiation exposure, when the Geiger counter was invented, or we still don't know or appreciate the dangers. So we're going to run a film from Scattered Denial, and then we'll come back with the answers.
How did we get here? How did we get to the cardiac catheterization laboratory? So what exactly is this mural?
This is a mural of things in medicine, things that...
The history of medicine?
History of medicine, exactly.
Who's number 28?
So that's Röntgen, the discoverer of X-ray.
The history of radiology begins with Conrad Röntgen, who discovered and developed the use of ionizing radiation to see through a hand, and first demonstrated that you could see bone through skin.
This is an image of the first radiograph taken in 1895. As soon as he developed that film, it became an international phenomenon.
In the beginning, many people using radiation, because you couldn't see it, feel it, or really be aware of it, didn't fully understand its potentially damaging effects.
Not too long after that, in 1904, a gentleman by the name of Clarence Dally died from an overexposure of X-rays. He was working in Thomas Edison's laboratory in the development of a fluoroscope X-ray machine. He went through multiple amputations before he finally died from the overexposure in 1904. Edison's reaction was not good. Edison basically said, I will have absolutely nothing to do with X-rays or radiation from here on.
Well, as we walk into the cath lab every day, we're exposed to radiation. We're exposed to radiation every day. It's coming from the sun, it's coming from the ground, it's coming from bananas, hazelnuts, Brazil nuts. We get radiation. But our body's designed to protect ourselves from that, to heal that. But we're putting ourselves, as our profession has grown, in a very unsafe environment where we get recurrent higher doses of this radiation, and it's affecting us. So as we see kind of from the beginning to where we are now, how did we get here?
Well, it's interesting. We started off with simple cases, simple, short cases, and our radiation exposure. And I'm going to use the term our lead exposure. It was brief, it was short. And we really didn't worry about the issues related to radiation, the dangers of radiation. We didn't think about it. Radiation's invisible, it doesn't have an odor, et cetera. We didn't think about that. And I think we were passionate. We were on fire with the technology, and we were passionate. We were driven by outcomes. You know, STEMI PCI, saving lives, extending lives, improving the quality of life. It was as time went on that we began to understand that there is this potential invisible killer called radiation, and not only was radiation
Dr. Dietrich
safety became an issue, but orthopedic issues became an issue because of the lead apron we were wearing.
Yeah, if you look at the radiation exposure, one of the biggest things is understanding the radiation. And I think that's where we've really fallen short is do we understand the effects on our body? And you know, everybody has different responses to radiation, and that's one of the biggest issues that we have is what is that response? What is your body's response?
What's that threshold for each one of us?
What's that threshold for you? And we've been talking about ALARA for I don't know how many years and years, always ALARA. But now what is reasonably acceptable? Is that changing? Are we, as we're getting into these new technology, is what's reasonable, acceptable something new that we need to set those new thresholds for that? So, you know, one of the biggest issues with radiation is our susceptibility to that cancer and that fear of cancer. So we're going to ask a second poll question now. And yeah, so sure. So on the previous poll questions, if we have those answers on whether or not really when was radiation dangerous? And most people thought, you know, when it was first discovered. So is that really, if you look at Thomas Edison said, you know, don't talk about X-rays. After he saw what happened,
I don't want anything to do with it.
I don't want anything to do with it. And you see these images of this right hand of Clarence Dally that's been totally radiated. He eventually lost his hand, he lost his arm, he lost his life. And he was in his 30s, and he said, I don't want to go down that path. I don't know what this is doing. You can't see it, you can't feel it, but it clearly has some devastating consequences. And that's really where we are. So, so now we're gonna have the next question. So, does chronic radiation exposure cause cancer? First, no, it does not cause cancer, or possibly, but we need more information, or not sure one way or the other, or I think so, but we need more information, or yes, I have no doubt it does. Let's watch the clip.
Fearless. He took patient care head on.
My motive was make it safer and make it simpler. And that is the real thing that led into the endovascular field, where you didn't have to make an incision, you didn't have blood loss, patients could be discharged sometimes the same day.
Dr. Dietrich was a cardiothoracic surgeon who was one of the first to actually get into the peripheral world of doing this. It was left to interventional radiologists and cardiologists.
Ted had an enormous interest in getting in cutting-edge technologies, and he was always at the forefront in the development of many things.
My whole mindset was, we're going to do the procedure, we're going to show people how to do the procedure, we're going to be the leaders in the world in the development of devices for the technologies that we want to conquer. And the last thing I was thinking about was, how much radiation am I exposing my body to? I think I felt this radiation cannot hurt me. It can't hurt me. I felt indestructible. Obviously, I didn't know what I was talking about, did I?
I think that his death brought a real awareness to all of those in the endovascular world about the risk of radiation exposure working in the cath lab.
It is a controversial subject, and not totally proven that people that have been exposed to X-rays will or had developed brain cancer. It could have been coincidental, or it could have been a causative factor, but it's not totally accepted that that is the case.
So let's go over the poll numbers as the results. And I think, overwhelmingly everyone feels like that there is no doubt that this radiation exposure that we're exposed to does cause cancer, but it's very complex. So Dave, let's talk about that.
Yeah, what was interesting, what Dr. Dietrich had to say, the first thing he said on that clip that you saw is he said, I wanted to make it safer. And that was our obsession, was making it safer for the patient, but not necessarily did we consider what is safety for the operators, the nurses, and people in the cath lab.
Yeah. And we continue to expose ourselves. And we do see there is some data that does talk about brain cancers and the risk of brain cancers, and the left-sided particularly risk, because that's where most of our body is exposed to. But those risks, it's very hard to correlate. There's just not big enough numbers typically. But we know, we keep seeing these people and our colleagues that continue to have these recurrent episodes with different kind of cancers. We know that the brain is probably, if you ask interventionalists, they say that's what I'm most worried about is my brain, which is something the lead apron doesn't cover.
Right.
So, and it's because we're just constantly getting that left side, and we seem to be getting, at least in my experience, closer and closer to the source as we're doing these complex procedures, and certainly on the pedal a lot longer. But it's not just the brain. It can also be your bones and certainly breast tissue that's exposed because of ill-fitting lead aprons. But it also a skin issue. So we're going to bring in Dr. Tom Eagan from Birmingham. He's going to help us out with this a little bit, kind of share his journey. And Tom, welcome.
Thanks for having me. I appreciate it, Bob. Thanks, David. To you too.
Great.
Good to see you guys.
Great. Well, fantastic. Well, tell us a little bit about your journey and what experience that you had. I know, I was lucky to be in your shadow in Birmingham as you were just, you were a very stellar, high interventional cardiologist in Birmingham, and certainly a thought leader in our space, and then had to step away. So tell us a little bit about that.
Well, it's kind of like what Dr. Dietrich and what you guys have already said. Remember, interventional cardiology was started by Grunzing in 1985. And I started my training in the late 1980s and finished it in the early 1990s. So as David mentioned earlier, we started out as interventional cardiologists doing quick, short procedures, which then ultimately became very long, extensive procedures. And because we were relatively new subspecialty of cardiology, we really didn't take into consideration the exposure to radiation or hazards in the cath lab. We were really focused on the disease, taking care of patients, developing this new subspecialty of cardiology, i.e. interventional cardiology. So when I came out in the day of balloon angioplasty and ultimately with stents, which helped revolutionize interventional cardiology. But in my early days of training, I was working 5 days a week, doing 10 to 20 procedures a day. And I continued that type of work for the next 10 to 15 years, and doing ultimately, after 20 years of work, about 30,000 procedures, most of which were interventional procedures. And then in the early 2000s, I started to develop skin cancers, and most of them were on the left side of my body. And it was originally attributed to just previous sun exposure, genetics, and just keep working, keep going, don't worry about it. And so I did. And then in the late 2009, it really got serious. I was seeing a dermatologist, started out every few months, and then weekly, and then I had to go to the dermatologist every single day. And when that happened, the folks that were seeing me said, there's a problem here. I don't know if you've got a genetic disease or you're real sensitive, but something's going on. You need to remove yourself. Let's get some better experts. Let's evaluate you. I was then presented at grand rounds at the University of Alabama, then sent to the NIH, and was there evaluated by a team of physicians looking for a diagnosis. What was the problem? And the consensus at that time was radiation was in effect, and that I should remove myself from the cath lab. I ultimately published my case report in 2011 to bring awareness on this issue, just what we're doing here today, in the Journal of Interventional Cardiology. I was bound and determined to get back in the cath lab because this is what I did. This is what I do. I went around the country. I looked at different radiation protective equipment, new devices that were out around 2010, 11. And then 2012, 13 time period, I said, that's it. I'm now in remission. Exposure's gone. I'm feeling better. I want to get back in the cath lab with this new equipment. So I went back in the cath lab, worked for another 4 years, and re-exposure, tried to use some protection, but as we all know, sometimes it's not practical. Do a lot of high volume cases, trying to take care of the patient. A lot of the PPE is cumbersome. There are orthopedic issues. And so went back to the light lead and back to high volume procedures. And then ultimately, after re-exposure, redevelopment of disease, 50 plus cancers on my left leg, my left arm. And then I was removed from the cath lab again. Interesting enough, went back to UAB, was presented at grand rounds again. And they say, you're really interesting, Dr. Eagan. This is really an interesting case. You have now shown a cause and effect. You've satisfied a Koch's postulate. And, great. Thank you very much. And so, but anyway, I went ahead and took myself out, and I've been out since then at that time, and now back in remission and working part-time as a general cardiologist, and republished my case in 2017 in CCI. And so if you want to read about it, all the effects, it gets very complicated. I tried to go through these 2 articles that I wrote about the effects of radiation. As we know, it's complicated. You can talk about the amount of scatter, dosages, skin, absorptive dosages, total dose, timing. It becomes very complicated. And I guess to summarize my case, and when I was going around the country trying to ask specialists, what happened, what was wrong, how did this happen to me, I talked to the folks at OSHA. And the head of OSHA gave me an example of a case that was study that was done by the NIH. And it was a study done on uranium mine workers in Virginia. And what that study showed basically was it is complicated. There are other factors. There are genetic factors. There, for instance, in uranium miners, there's silica, there's dust. There are individual factors having to do with patients, where they live, did they smoke, et cetera. But what they ultimately determined from that study was what was seen in the atomic bomb study, the atomic bomb study of the Japanese individuals that survived the atomic bomb, was that the exposure to ionizing radiation is a linear, no threshold effect. And that's the stochastic effect. So at any effect, at any dose, there can be a DNA breakage and be carcinogenic. So linear, no threshold. And I think that is the takeaway. And in my last article that I wrote in CCI, as you alluded to earlier, that we have always followed the principle of the law, but I suggest we follow the principle of the ants, which is near to zero as possible. And that's my summary. And I really
let me ask you
this.
something.
Yes.
So
Go ahead, Dave.
80% of these were on the left side of your body, correct?
So if you look at my original
80% of the cancerous lesions. Yes.
Yeah, if you look at my original article, David, in 2011 in Journal of Interventional Cardiology, and I described all of the cancers, 97% were on the left side, left arm, left shoulder, left neck, left temple, left lower leg, just at the knee and below the knee. Only 2% to 3%.
I know
on
one
my
of the things that we're trying to do. I know one of the things we're trying to do is raise awareness. And a quick question for you, because I think it's interesting because it was like to see if your experience was the same. But when your partners watched you go through that, and did they just think that that was an issue with you, or did they make some changes to go, wait a minute, you know, I see firsthand my partner, my friend is going through this, and so I need to protect myself. Did they make any change at all, or did they just say, well, this is just a Tom Eagan problem?
No, well, they did, Bob, but I also thought they felt the same thing, that hopefully it wouldn't happen to them. And we know, as you know, a number of interventional cardiologists have suffered left-sided brain cancers as well. But when I came back into the cath lab, I brought some new protective equipment that I introduced into the labs that I worked in, and just about all of my interventional partners began to utilize more protective equipment, a number of new devices. So I think that was a good thing. But as you know, Bob, and you know, with your with what you've done, that a lot of these devices are not perfect, and they have some practical considerations as we look at protection in the cath lab. But one of the things that I think I have helped is that my partners did start to utilize some of the newer protective devices to lessen their exposure.
Good. So, what I want to do now, and thank you, Tom, that was fantastic. And I think that real world experience that, yes, you know, it's not just a problem with you. We all need to be protected. And most of us, although we haven't gone so deep into our skin that we have the cancers, many of us don't have hair on our legs, at least on the left leg anyway. So it's clearly affecting us. Clearly affecting us already.
Bob, may I just, I thought you asked probably just such a great question, a fantastic question. How did your partners look at this? You know, when we look at statistically the risk of cancer, it's 1 in 25 in the general population over their lifetime, but it's a 4 to 5% absolute increase, 4 to 5% absolute increase in interventional cardiologists. Do we as interventionists look at people who have experienced cancers and whatnot and say, well, I'm not going to be, is this the ultimate form of denial?
I think it is. I think it is. I think we think that, oh, well, that's not going to happen to me, and the numbers are low. But, and I do think if you look at overall, your cancer risks are fairly low. Your biggest risk is orthopedic, and that's what we're going to get to next.
Right.
And really looking forward to this discussion. So we're going to start out with an orthopedic poll question and just see where everybody stands as far as the orthopedic side. So if you work in a cath lab, what are your chances of developing a severe orthopedic injury from wearing the lead apron? Is it 3 to 4%, the same as the general population, 10%, 35%, or over 60%? And so let's show the clip from Scatter Denial.
There's another type of exposure that we face after being in the cath lab. And it's not just the radiation exposure, but it's wearing these lead aprons. Remember, the lead aprons are about 30 pounds. When you think about doing thousands of procedures over many, many years, that lead apron starts to take a toll from an orthopedic standpoint. Knee injury, hip injury, back injury.
My name is Bob Foster. I'm an interventional cardiologist from Birmingham, Alabama. I've been an interventional cardiologist about 30 years. I've probably done 12 to 15,000 procedures. Even early on in my practice, doing very long cases, I felt the orthopedic strain of wearing lead apron. I was very active doing, running long distances, doing triathlons. That was my passion. And then after about 15 years of doing these procedures, I ruptured my first disc. And the orthopedic surgeon told me at that time that a lot of it was because of the lead apron that I was wearing, and just wearing that weight day in and day out is putting too much pressure on my spine.
Well, the idea with wearing lead is it's just extra stress being put on the back and the spine. And so with cardiologists in particular, they have to wear those protective clothing. It's like being a fireman. They have to wear 80 pounds of gear to go into a burning house. Well, sometimes it gets to where you can't do that physically.
Well, let's look at the poll questions and see. There have been, and this is true, it's over 60%. There's been several SKY surveys, one in 2004, one in 2014. We just did one in 2024. And in the first two, we don't have the results of that one. That'll be revealed in SKY. Looking forward to that. I think Dr. Hermiller is going to do that. But the first two, there was basically no difference. 60% of the time, you're going to have a disabling back injury if you've been in practice for 20 years. But we also show that those patients, those operators that are in there, 5 to 10 years are already having back injuries. So it's not this linear, slow, progressive thing like cancer. You get it early on and it's sustained and it becomes disabling. So that's where we are. One of the questions that was asked is how much do we have to protect? What is the minimum amount of protection for radiation? And you want to answer that?
Well, I think we're at the minimum. I think what we're doing right now is minimum, and we have to aspire to greater protection. I think making it the point, reinforcing the point, 2 points. First, as scary as cancer is, as horrendous as Dr. Dietrich's cancer was, you're more likely to have orthopedic injury. But think about the people with whom you're surrounded in the cath lab. You and I go into the cath lab, we do 2 or 3 cases. The nurses and patient care technicians in the cath lab are there for 7, 8, 10, 12 cases a day. This is not just about physician-related orthopedic maladies. This is the entire cath lab, just like radiation exposure is the entire cath lab. So the solutions really must be directed at the entire cath lab, both in terms of radiation protection and the ability to shed the lead apron.
Absolutely. And it's usually the highest volume operator, your most skilled teams that are getting taken out. And, what impact does that have on the hospital as they start backing off on their workloads and reducing their number of cases? And what impact, more importantly, does it have on the patient when you don't have the best operator at the table and the best team at the table, because it takes a team to do these?
Turnover is expensive in 2 ways. It's got to be, turning over physicians and nurses and patient care technicians has to be financially very expensive. But there's also an expense in terms of quality. If you are constantly turning over, think of your favorite nurse that has scrubbed next to you, the kind of quality that he or she might bring to being to the right of you. But think about how we lose that as we continue to turn over staff in the cath lab, not just physician staff.
Absolutely. So, my experience was very similar to Dr. J Kereiakes, who we're going to bring on, and mine was a back injury, disc rupture, paralyzed leg, out of the cath lab, completely for over a year and out of work completely for 3 months. So it was a very devastating part of my life. And going through that, not knowing, you know, all of this energy, all this work, all this passion to take care of patients, and then I couldn't do it anymore. And what was I going to do next? What was that journey going to look like next? So Dr. Kereiakes is joining us from the Ohio State, and welcome, Dr. Kereiakes, and we really appreciate you coming on and telling your story.
Oh, thanks very much, David and Bob. You know, I felt pretty much the same way. It's an interventional cardiologist, young interventional cardiologist, and you guys remember that lead weighed at least 30 pounds in those days. This is the mid to late 80s, early 90s. I was doing 14 to 1,500 procedures a year. Many of the procedures that you recall, like bailout, directional pulmonary atherectomy, you know, these things would take hours, complex procedures. Because in those days, we didn't have stents. Things weren't quite as quick and easy. And I had my first emergency disc operation, discectomy, the week right prior to my 38th birthday, actually. It was January of 1991. And I had been on call, taking care of a STEMI. I'd had a lot of sciatica, and I was putting it off until I could have a vacation and get my disc done then so that I wouldn't miss any time. And I took typically 2 weeks. That was it in those days, vacation year. So I was putting it off, and I got out of bed, and I didn't realize I tripped, fell down. And the reason I tripped is because my left leg was paralyzed. And I was taken by ambulance and had an emergency discectomy. And I wasn't out of the lab for very long, interestingly enough. I came right back to the same volumes, et cetera. Had left arm and left hand muscle wasting, mild residual left foot drop. But when I would get sciatica, I would put myself on prednisone, 30 milligrams a day for a couple of days and taper. And that always got me back in the game. And I never really thought that, and so this went on for years. And then I started to get, my problem was rather acute. I knew I had chronic cervical cord compression with some gliosis, and I had been followed for several years. I was physically intact. Strength was good. I was told that there's a risk of the operation that might be out for several months. And again, don't ride horses, don't go skiing, be careful, don't do anything, don't fall down the steps at night, things like that. And so I did all those things. I quit playing golf, et cetera, which I never played much, but I took no chances. But suddenly, and I think it was after a couple of busy weeks in early February of this year, you guys know, it was February 3rd, 4th, and 5th, I started having symptoms in retrospect of cervical cord compression. I started to have lack of coordination with my arms and hands. I couldn't sign a check going out to dinner with my wife. And then I had this form of pain in my back, and my arms felt incoordinated. And so and now I was going to fall down. So I laid down on the carpet, and about 10, 15 minutes, it kind of went away. So I did what I always do. I took 30 prednisone, and thought, this is going to help. I'll be better. Right around the corner the next day, Monday, I get up to put my scrubs on, go and do some TAVR, transcatheter valve replacement. Pain comes back in the back. I had a floppy right foot, which really didn't make me happy. And then I started having the loss of use of my hands. I couldn't dial my phone from my dressing room. So I started yelling for my wife to wake up. And she did. And she called the emergency medical system. I went in to the Christ Hospital in Cincinnati, where I've done over time, close to 30,000 procedures. And a span of almost 40 years. And I got MRI, and it was clear that I had cervical cord compression. My cervical spine was fused from C3 to C7, and there was a gap at C3, which meant that if I had fallen down the stairs or gotten hit from behind by a car, I could have been transected at the level of C3. So that Monday night, I was going downhill despite high-dose decadrine, solumedrol, and I call it the praying mantis pose. And any neurologist, neurosurgeon that sees this knows exactly what I'm talking about. Your arms are flexed up, your wrists are flexed down, and your fingers are totally spasmed together. And people said, well, did you realize what was happening? And I'd be like, are you stupid? And I said, well, when these things happen, there's a great deal of denial. And I also just wanted somebody to help me. I asked my wife, I asked my nurse, can you open my fingers? Can you just open my hand? And I was like praying mantis, and I couldn't move my legs. So I was transiently quadriplegic. This was recognized immediately by my neurosurgeon. They took me to urgent cervical spine decompression, which the quickest way was not to do an anterior approach, but basically to unzip me from hairline down to almost my shoulder blades. So it's a long incision, decompress the spine, and then fuse both top and bottom. I came out of there without the use of my right arm and hand, which, has come back, and my right leg. And of course, a bowel and bladder function, and you talk about, listen, I'm telling you, my heart goes out to anyone who never recovers. You have my deepest empathy, because I was in the hospital for a month, intensive PT, OT. I am now about a month out, and I'm walking with a cane. It's nothing short of miraculous. I think it's like stemming, aborting a stemming in that golden hour. If you act quickly enough, and there wasn't transection, it was contusion of the cord. I had what's called Brown-Séquard syndrome. So I still have a lot of paresthesia. I can feel cold on the right side, can't feel ice cubes on the left side. I'm walking with a cane. And frankly, I'm going to start seeing some patients in the office next month in May, which is about a historic type of recovery. And the hospital is committed now. The Christ Hospital is committed to lead-free radiation protection. And I will be back in the lab. My love, I said this to you, David, we are what we do, and what we do is who we are. I am an interventional cardiologist, a medical man. I've spent my career evaluating new technologies. I can't separate myself from that. So without lead, I will be able to still hopefully run several IDE trials in the coming couple of years for evaluation of novel technologies, breakthrough technologies. So, but this is certainly great surgery. And I think, honestly, will of God, when you have an event like this and you know what it feels like to be quadriplegic, even transiently, and come out of that and not know if you're going to be able to walk again ever. There's a huge moment of pause and reflection, I can tell you that. But I am going to go forward. I am not going to allow this to define me, to defeat me. I'm going to go back to being who I was, what I was. I will never wear a lead apron again. Thank you.
Dean, this is such a moving story. I've heard it said about you that your face belongs up on the Mount Rushmore of interventional cardiology. I think you helping to be the spokesperson, you being one of the Christ figures for this. We can talk about this all the time, but it may not get noticed. But when someone like you becomes the Christ figure for this, I think that's going to move the needle, don't you?
I do too. And I think people will, all the people watching this, you think, well, that can't happen to me. It can. I think was one of the things that, of course, it puts my paralyzed leg into a whole different perspective that I shouldn't have whined about it with what you've gone through. But wow, if you think it can't happen to you, it can. And interesting about your story is that yours happened when your first disc problem when you were 38.
Early career.
Mine was 41.
Early
my first
career.
So that's very early career. And so it's not just, you're seeing us coming on as maybe a little bit more senior, but it's happening to us the day we step in that lab. That's when your injury starts.
Dean, you sort of remind me, I remember the public service ads back in the 1980s. The famous actor Yul Brynner, he developed lung cancer, and he said, I denied all those years it could happen to me. And that was a call to action to keep young people from ever picking up a cigarette. I think what you've shared with us today is a call to action for young interventionalists to take this seriously.
I couldn't agree with you more. But again, it's a sense of invincibility. I'd be told that my badge was hot in the 80s and 90s. And so my solution to that was to put it in the drawer. Don't wear it. And my dad was a radiation safety officer for the hospital, for the Christ Hospital. And he's a professor of radiology at the University of Cincinnati. Now that is, I think younger people today have a lot more consciousness about life-work balance than we had, or than I certainly had. But if you're going to tell me that I wasn't going to do more cases and I wasn't going to take the referrals that were coming in, I was not going to listen. Okay. And David, Bob, I'm sure you guys were the same way. We worked hard to build a massive practice. We took great care of the patients. We cared about it. And in those days, we really took care of them. We had no fellows. We did everything that it was on us. And you couldn't talk sense.
We have so much.
This is the first time that I said to myself, David,
we have so much.
I need to cut back.
We have so much high-level scientific evidence for what we do in the cath lab. We probably don't have the high-level evidence that we need to tell the story about orthopedic injury. Do you agree with that?
I agree, and I think that's one of the things we really need to highlight is what is out there. And I will say that if you join ORSIF and go to the ORSIF website, it's free to join. We've got a library there. So if you look and search in the library, orthopedic issues, we have the latest manuscripts in there. So we're continuing to build that library. So another advantage of kind of coming into ORSIF, looking at that, but you'll see there is a paucity in it. And we do need to, we know it, that, we mostly have surveys. We know it, we feel it, we have to report it in these surveys, but really, really long, robust data is just not there.
Right.
Yeah. So, well, thank you, Dean. That was fantastic.
Thanks,
and
Dean.
Praying for full recovery for you. We need you back. You're certainly a mentor and a guide for all of us. So we're going to now move into women in the lab, and so let me share with you this first poll, and let's just see what everybody thinks as far as why women why there aren't more female interventionalists. So is it historically it's been men and it just takes time, or it's a tough work-family balance and some don't want it, or fear of radiation and its reproductive implications, or women simply aren't interested. So let's watch the clip.
As physicians and scientists, we are really data-driven. We look at large trials to determine how we make decisions for our patients. But when it comes to radiation exposure in the occupational sense, we're really limited in the data that we're relying on. These are observations and extrapolations from Hiroshima, and that kind of data might not be as solid as we need to really understand what the true risk is to physicians and operators who are exposed to radiation on a daily basis. I did a survey, a national survey with the American College of Cardiology, asking almost 600 fellows in training why they were interested in going to interventional cardiology and what were the reasons that they might not want to. We found that men were much more likely to be interested in the field, but not for the reasons you would expect. Women were much more concerned about radiation exposure, particularly during childbearing years.
Well, I think that when my colleagues are pregnant, then it becomes a huge issue because we don't really know what is safe and how much is safe.
The most at-risk person when it comes to radiation are young females. So yeah, that definitely makes me think of, am I gonna struggle to get pregnant because of what I've done for a career? Cancer runs in my family pretty prevalently, so did I just increase my risk of getting cancer? Who knows?
Well, let's look at the poll. So most people feel that, and it's kind of between the two of that work-family life balance and the fear of radiation. Well, I want to bring in Rhian Davies from York, Pennsylvania, and we're certainly Dave and I certainly aren't experts at this, and Rhian's going to give us her perspective of where she's been able to kind of navigate through the interventional labs and now becoming one of the leading CTO operators in the world. So welcome, Rhian.
Thank you so much, David and Bob, for doing this. This is phenomenal so far today. As a female, I'm an interventionalist. I'm in my early career. I've been practicing now for 3.5, going on 4 years. Prior to that, did 2 years of training in interventional and the CTO year. And throughout that time of training, my main focus was not radiation safety, to be honest. In my mind, I was kind of ignorant to it. And it wasn't until halfway through maybe my second year of training that I really started to worry more about it. And I think that's a little bit because my procedures were maybe a little bit longer than the standard diagnostic cath kind of procedure. And the worry of what am I exposing myself to, what am I exposing my staff to really became a forefront of my attention. And we were using robotic PCI at that time a little bit more, and that was a way for us as the operator to get out of the lab, but still my staff was going to be exposed. So we tried to come up with fancy ways of putting lead shields in there, in between them and the patient while they were in there working on the robot. And as I moved out of training and into my current position here in York, that really continued to be in the back of my mind. And when we heard about the idea of a leadless room and lowering the radiation exposure to you and who's at the table with you, I wanted that opportunity provided in our lab. And I'm fortunate to work in a health system that let me get devices in our labs. We were able to get Rampart, and this enabled me to do my longer cases and remain away from the radiation exposure and keep my staff at the table with me also safe. And we figured out, the right way of setting it up and really limiting and minimizing that exposure to the other folks even in the room. And through that, it's really made a huge change in the procedures that I do. Not only am I not exhausted from wearing lead at the end of the day, it's just made the team happier too, because anytime you don't have to be wearing an additional 10 to 15 pounds on you, I think anybody's going to be happier.
The decision points that you made when you decided to go into interventional cardiology, that was the first one, which I guess we asked earlier, is why aren't more women? That's probably the first decision point that they say, I'm not going into cardiology. And then the second, to go into a subspecialty of intervention where you're doing extremely long cases with these complex PCI. So tell me a little bit about that. What was your thought process there?
Very early on during my general cardiology fellowship, when I started throwing interest around that I wanted to go into interventional, a lot of folks outside of interventional even were telling me, no, this isn't really the field for a woman. You know, you're going to be exposed to radiation. And to me, that didn't really concern me so much, but it was not one or two people. It was many people that were telling me this. And I think that's a big negative. And maybe we shouldn't have been so focused on diverting people from starting this career path as we should be as changing the radiation exposure and lead and having more freedom in the cath lab with different devices to allow you not to wear the lead. That should be more of the focus. But it certainly was something that was said to me quite often. And I obviously fell in love with complex procedures and CTO procedures during my training. And my viewpoint was, I'm going to do this. I'm just going to figure out a way to do it and try to allow me to do it for a prolonged time. And the best way to do that is getting out of lead and protecting the staff. And fortunately, there are more and more devices coming to market that allow these sorts of this sort of idea to be a real thing, and allowing more operators who are interested in interventional cardiology and interested in those sort of procedures that may be a little bit longer to really do it and not worry about that radiation exposure.
You sound like you're in a very fortunate situation. People at your institution are forward-thinking in terms of protecting the operators, but not everybody is in that situation. In fact, most people are not. These have not become the standard of care. You know, it's 2024. We talk about diversity, inclusiveness, women taking more leadership roles in interventional cardiology. Yet, comment on the fact that it's been 7 or 8 years since Selena Young wrote that beautiful op-ed piece, and we haven't done enough. How do we move the needle?
I think it really comes down to being upfront, being aggressive, sometimes even with your administration. I have a lot of female colleagues and friends of mine that are in similar positions at institutions that don't want to listen to them. And sometimes you just have to continue to talk to them, send emails, give them calls. Just really, it shouldn't be this much of an effort for hospital and health systems to see the advantages of radiation protection devices. But unfortunately, you know, sometimes it's not as easy for them to say yes or no. But with that being said, there's support from industry, there's support from philanthropy programs that the hospitals have. And I encourage anybody that's in these positions or in labs that don't have any radiation protection systems, that they continue to fight the good fight and bring awareness to their healthcare team and administration that if they're not doing the jobs and they get injured or they get problems from the radiation exposure or wearing the lead, they won't be working, their team won't be working, so there won't be any profit for the hospital regardless.
Yeah, I think it's really exciting. And we saw Dean Kereiakes here, and as you said, I mean, just a thought leader, and his voice telling his story and telling the time for change. And Rhian, I think you're in that same position with women in medicine and all the leadership roles that you're playing in that. I think your voice, and the nice thing about you is that you haven't gone through those injuries yet. You know, those of us talking about the injuries we've suffered, I think are one thing, and that enlightens our passion to say we've got to change this next generation. But you know, you're one of the ones that's getting it, and you know, trying to get this next generation to get it like you do. We've just got to, you know, like you say, I think it's going to be education and just aggressiveness and exposing people to what the real reality is out there.
Exactly, the exposure.
We're gonna. Go ahead.
The exposure is key.
Go ahead.
And folks who aren't willing to listen, you just look at colleagues, mentors. I've worked with so many physicians now that have ongoing health issues with orthopedics or cancer issues. And those are docs, those are nurses, those are techs. If we don't listen and we don't change, it won't be any better for us. So continuing to advocate for early mid-career and making that change now is what's important.
Fantastic. Well, Rhian, thanks for joining us. That was great. So we're going to move on to the next question, the next poll question, and talk a little bit about solutions. So are there solutions to these radiation orthopedic problems? And is it not yet, or not yet, but they're coming, or I'm not sure, or yes, but they need more work, or yes, they have arrived? So we're going to watch the clip.
You know, the idea that we wear lead on top of us, you know, and we carry around our own shield basically with your own spine is just, it's almost laughable. You know, I mean, I think that we protect the chest with lead. And it's never really like entered people's minds before that, like, why are you standing here getting your head radiated? And I think, you know, there's several systems available around the country that are geared towards mitigating the radiation exposure to the room. We have a shielding system here that's really nice. It's a 1-inch thick lead shield that basically sits over the patient and blocks both the radiation from the source as well as most of the scatter radiation. So we actually do not wear lead.
The newer technologies are really a barrier protection. So you place this barrier. It's taking off the personal protection and giving you a community protection. So if you think of radiation as basically a source of light, then you want to stay in the shadow of that light.
This will fit as a half moon over the patient. Now it's going to block the radiation coming from the image intensifier. Now think about this. Think about what a monumental movement forward this is. Less radiation exposure to the physicians and nurses, almost no radiation exposure, and taking the lead apron off the physicians and nurses. Now, this has the potential to be game-changing technology. We have done research in our cardiac catheterization laboratory on one such system. And you could do, based on the data we have, you could perform 1,000 procedures a year. Now that's a lot of procedures. You could perform 1,000 procedures a year and still only be at 2% of the maximum allowable threshold for radiation exposure in a year.
Now you have to remember, this is only protect the people who are sitting on this corner on this side of the patient. If person this side of the patient, they have no protection. They still have to wear a lead.
Well, David, this is going to be a fascinating discussion now.
My favorite part.
So now we're getting into solutions. And I think it's because it's a call to action. It is a time for change because we haven't had those opportunities really until now. And so now there are multiple different types of protective devices on the market. We've got the Protego we saw Rampart, we saw Egg Nest. There are others. Even the lead aprons are even good. They're very specific for women. They cover their breast tissue better and axilla better. It needs to be fitted. It needs to be right. And we also have great monitoring devices that allow us to monitor so we can make some changes in the lab so we know where the radiation where the radiation is coming from and how much we're getting personally.
And I think the real-time dosimetry is an extremely important point.
I think it is too. So now, we're not probably quite there, but if you were to say, what is the Holy Grail? What are we striving for?
The Holy Grail, let's see. So I would say a couple of points. First, it has to be broad spectrum protection, broad spectrum coverage. And that means zero radiation. And that means zero radiation from head to toe. And that means zero radiation for the entire lab. So if we're talking about the Holy Grail, it's broad spectrum coverage. And as you said earlier, for radial and femoral access, so there's no limitation in terms of radial and femoral access.
Yeah. One of the difficult parts of protecting everybody in the room is all of these rooms look different. All of the procedures are different. Access sites are different. And again, that makes it so it becomes a real challenge.
Becomes a challenge.
Because we've got we're talking a lot about cardiology, but there's other subspecialties there that haven't even touched. And so when you get into the complex endoscopy, when you get into orthopedics, when you get into urology, when you get into some of the spine work, all of them are in the same situation we are. It's just a unique way of protecting them that really has to be evolved.
We won't reach the Holy Grail, though, until we hit all of those parameters, zero radiation to the entire staff, and we shed the lead apron. Because as bad as radiation is, the orthopedic downstream maladies of wearing that lead apron for all of those years is what interventionalists are more likely to encounter.
Absolutely. There are other opportunities here, and we know that these big iron imaging companies are doing their best for collimation. Certainly, we try to do our best for staying off the pedal as much as we can, and for fluorosave, and we have ways that we can reduce our radiation as well. But there are also some very innovative co-registration, MRI. There's ways that those technologies that don't emit this low-level ionizing radiation, I think, can help us at least prepare for the cases better and allow us to reduce the amount of radiation that we're getting. So we're going to go to another poll question, which is going to be a challenge for everybody because I think it's exciting and it really is putting your actions where your thoughts are, and it's a challenge. So, the question is, are you willing to walk away from your job if your employer does not provide adequate radiation protection? That's walking away. Not likely, possible, not sure, I would think about leaving, or would definitely walk away. So now let's watch the clip.
So like CTE in football, radiation has another similarity. No one wants to talk about it. We tried to talk to a physician whose hospital administration refused to purchase one of these new barrier systems. So he bought it with his own money. And to no one's surprise, they also refused to let him appear in this film.
Did you get the email chain and the text chain where it's like, David, I don't think I can fight this.
People are afraid of these topics.
I think it's a prime example of what it is we're up against.
There is no doubt. Listen.
An interventional cardiologist is willing to take the risk because they want to do the greater good. And I think that's incredibly admirable, and it's kind of a very unselfish individual that is willing to do that. But at the end, I think that society and hospitals in particular really owe it to the doctors to give them the safest environment possible for them to do their job.
I think it's the responsibility of the health systems that we work in to put you in the safest environment. And currently we're not, and there's better options out there. And what'll happen eventually will be the same thing that happened in the NFL. You'll have a group of people that have had orthopedic issues, or you'll have a group of people that have had cancers from the radiation, and you'll have a class action lawsuit.
I don't want this to sound like we're a bunch of victims. I truly believe that we do have ownership of what we can and cannot do in the hospital, because at the end of the day, we are the players. This idea that the administrators don't want to support it, or this or that or the other thing, I don't truly buy into it.
I think the good hospitals, the hospitals that really are known for being able to take care of their doctors, will generate a lot of loyalty, and that will be good for business.
Let's go to the poll and just see what everybody says. And wow. That's impressive.
I didn't see this coming.
Well, I can tell you that is probably the most exciting thing that I've seen, that 55% would walk away if they don't get the adequate protection.
And it stresses what we're saying, the need for protection. If over half of staff, physicians would walk away, that's a monster number.
That's a big number. The other thing that's very exciting is we're seeing so much interest. We've got a lot of questions that are coming to us, and those questions we're not going to have time to answer all on this live. But I will say that we will answer them all. I think they're very important questions. We're seeing them, we're watching them. We'd love to tackle them all, but are not going to have the time here. But you know, the solutions and development has been slow. Tell me a little bit about that, and where do you see this going, and where do you see some analogies?
Wow, this is a wide open discussion. You know, I think you're 100% right. First, solutions have been slow to develop, but equally slow, if not slower, to adopt. And that's a complicated calculus as to why that is. Number one, it's not reimbursed. You were asking CEOs of hospitals to provide this new technology for safety and protection of staff when it's not reimbursed. On the heels of COVID-19, where retention bonuses for nursing staff had been given out, we had traveling nurses. The margins in hospitals are razor thin, so to now go out and purchase these advanced protection systems when they're not reimbursed, that's a big issue. You know, I loved the analogy we just heard to football. Bill Nicholson talked about football. The owners, the NFL owners, finally got it right. They took seriously this issue of chronic traumatic encephalopathy or concussion syndrome, and they acted appropriately. The question is, if hospital CEOs don't do the same thing, are they doing so at their own peril? Are there going to be lawsuits? I mean, what's your feeling?
Yeah, I think that we're entering this era where there's going to become some liability issues because, you know, you want to have the best protection for your staff in any job, really. You know, you want to protect those who are, you know, in really any occupation. You want to provide for them the best protection for their occupation. And as we kind of get into this occupational health and wellness, it's not just cardiology, but you will be liable if there are safety measures. You know, the car companies did it, going from seatbelts to airbags.
Right.
And I think that now there's something on the block that we know will help spines and help, you know, save lives, and I think create this wellness that I think we have to adopt. You know, it's hard to turn the cameras back on ourselves and say that, you know, it is all about the patient, but I can provide better patient care if I'm not fatigued in the lead apron. I don't want to be the 7th or 8th patient that day in somebody who's wearing a lead apron all day long.
Boy, that's a great point.
Mentally, you get fatigued, and you cannot make a mistake in this profession. It's one of those things that one of those rare events that if you think wrong, if you don't do the right thing, then, you know, a patient could die. And so it's very important that we stay mentally clear throughout these procedures. And what we should not have to worry about is how much radiation we're getting. What we shouldn't have to worry about is what our future is going to be. Are we going to be able to pick up grandchildren? I'm in that phase, and you know it's tough. I can't run. I can't put my babies in a car seat. There's a lot of things that I can't do anymore, and it was because I sacrificed my body for this. And I think we're now entering an era where there is some opportunity for prevention. So. You know, I thank you, David. This was wonderful. I think this was a great discussion, and looking forward to more and more. We want you to join ORSIF. We thank ORSIF for putting this together. I think together we can kind of create some momentum. We can kind of create this cohesive power to move that needle. And anyone in the space, or really anyone in the cath lab, really ought to join. We'll have a lot of opportunities there to get more education. I want you to watch Scattered Denial. It's going to be in April 28th. And also on PBS, looking forward to that coming out. ORSIF is doing a Is Not Here campaign. And what the Is Not Here campaign is, we're going to, for one, memorialize some of our colleagues who are not here anymore because they have either passed away from cancer, passed away from the radiation effects, are not in the lab because of those radiation effects, have orthopedic injuries, or you know, some people are telling their stories about some of their colleagues, some of their female colleagues who aren't in the cath lab. And they're not in the cath lab because they chose a different route. So I also want to thank our sponsors. We have some fantastic sponsors who are in the space and supporting ORSIF to make events like this happen. I think we got a lot more events like this in the future. We want to appreciate the societies now, particularly in cardiology, that are now beginning to support this message. And I think as we see in these congresses and in these big session society meetings, I think we're going to see more of a front and center sessions on radiation protection, orthopedic protection in the cath lab. So I want to close with this final question, and that is radiation a problem in the cath lab? I think you answered this before, and now we're going to answer it toward the end and just see if there's been any change. So is it not really? Is it perhaps? Is it not sure? Is it I think it is? Or absolutely it's a problem in the cath lab? So let's bring that up and see if we've changed your opinion, or if you had pretty high thoughts of what radiation, that it was a problem early on, and you're still convinced that it is.
While they're answering the question, I want to thank you for being here in Arizona, but I want to thank you for the leadership and the foundation that you've set. You really have set the wheels in motion for this, and we owe you so much for all you've done in this space.
I appreciate it. I appreciate it. Okay, so as we look at the poll results, I can tell you so we have 92%, absolutely, and you know, I would say that matches a lot of the surveys that have been taken. It's about 90% think that it's a problem, and that's very consistent with that. And about 80 to 90% say the hospitals need to do something about it.
Exactly, and even if most people said, I think it is, shouldn't that be a call to action, even if you have a doubt in your mind? But I think the point has been made.
Points been made. Well, thank you all for joining us, and this will be posted on the ORSIF website so you can see it after the fact, or again, please recommend it to your friends, anyone in the space, to gain more education. We thank you for everyone who participated, and particularly our guests and co-hosts, and we hope to do it again. Thank you very much.